Well, thank you, Franca and Marco, for your kind invitation. The second time I come here for this very interesting opportunity. I have to show you. I will not show the results of experimental data of co-working we have with the University of INSUBRIA and with Marco and Franca. But I try to interpret the topic of this course, trying to have a wide review of the most important drugs we have now from treating multiple sclerosis, because most of them comes from the treatment of other diseases have been developed for other disease. And so, this is my disclosure according to the Italian laws. And this is the temporal landscape of the treatments for multiple sclerosis. As you can see, in the last years, the landscape is indeed very crowded of many drugs. And most of them are acting on the immune system naturally, but many of them are still not yet registered for multiple sclerosis, but they will be available in the next few months. This makes the job of a clinician sometimes a little tricky, because all these drugs, these new drugs, are very powerful for treating MS, but they also have several drawbacks. They have several risks, and this may also put the risk, another risk, that is the risk of jumping from one treatment to another. That will be deleterious, because the relationships between these different drugs, all acting at different sites of the immune system, are indeed sometimes very dangerous, I should say, because there are several side effects that may be life-threatening. But on the left side, you can see some of the very old drugs that we used starting from the early 90s. And interferon beta and glatiramer acetate. I will spend a few words about these drugs for two reasons. First of all, because they are very safe. We have a long experience with these drugs, and they still can have a role in the treatment of multiple sclerosis, unless they are not new at all. And secondly, because they helped us to understand several aspects of the immune pathogenesis of the disease, together with experimental models of EAE. And for example, some of this is the case of glatiramer acetate that now is available at a different dosage. That makes it possible to administer it not every day, but every third day. It will increase strongly the acceptance by the patients. This is not trivial, because the side effect at the site of injection may be very important, and this will surely will help to increase not only the safety, but also increase probably the effectiveness that was demonstrated a little bit stronger than it was in the previous formulation. Another case is pegylated interferon beta. I will not talk about pegylation. You all know what does it means, but this will change dramatically the pharmacodynamic of interferon beta, will make it possible to administer it every 2 weeks, or possibly every 4 weeks in some new formulation. They have been already studied. They show a very good safety profile, and also a very good effectiveness, reducing the number of relapses, the so-called the figure of the annual relapse rate that you will see in several slides. by 36%, which much even higher than it was for the normal older formulation. And this is true also for the reduction of disability and the reduction of the main MRI endpoints that in all trials have been considered and will be considered. And so this formulation showed a very strong effect in a new and very strong endpoint, very restrictive endpoint, that is what we call a NEDA. That is no evidence of disease activity. It means that we can select patients who are free from clinical activity, they are free from MRI activity, or free from both. And by this way, we can see that a large number of patients treated with interferon beta can still have a long period of disease-free from relapses. And the interferons also are important from my point of view, because it's the only drug that showed to change a very strength, powerful endpoint that is mortality. After 20 years of observation of patients who started to be treated in clinical trials and that were followed clinically for 20 years, the drug demonstrated, you can see here, a strong effect on late mortality that is an unmet endpoint for every other drug. As I told you, understanding how interferon and how glatiramer acetates are working in the network of the immune system, we could understand, together with the animal model EAE, the animal model of multiple sclerosis, what many of the pathogenic mechanisms of multiple sclerosis. Well, as you can imagine, the pathogenesis of this complex disease is much more complicated than this cartoon. Anyway, to make a long story short, I will recall you that we all have potentially autoreactive T cells coming from the thymus in circulating blood that can show particular features, and can be modulated also by environmental agents like the sunshine and vitamin D, after smoking, or possibly viruses or other environmental agents. After activation from unknown mechanisms, these cells are able to cross the blood-brain barrier to enter in the central nervous system, and here they can release many modulating soluble factors. They, together with not only molecular mechanisms but also cellular mechanisms that can destroy the myelin sheath and release a new small antigenic determinants of the myelin sheath. These determinants can get back to the circulation via the lymphatic drainage of the neck. That this mechanism has been definitely demonstrated, and after then they come back to the circulation, they come back to the primary lymphatic organs of the body, and here they can re-stimulate, the antigens can be presented to new T cells, and that become again reactivated, and so the loop starts again. And this is the main mechanism, we suppose, of the determination of clinical relapses that can be determined by the release of these new agents. Of course, the actors of this complex mechanism are several, and different cell types are involved. most of all T cells and dendritic cells that are show particular features in multiple sclerosis. We don't want to talk about this, but we know that these cells, when they are activated, show new cluster designation and are able together when they differentiate into activated T cells or suppressor T cells are able inside the central nervous system, as I told you before, to destroy the myelin sheath. This complex mechanism is mediated also by the release of antibodies by B cells. But now we know that also microglia probably have a very important role, not only in its structural role, but also because it can be reactivated and become an inflammatory microglia, releasing several factors that can be furtherly damage the myelin sheath. Also, mast cells, as we have shown in the previous presentation, may have a role. And so we have a network of different cell types that are susceptible of pharmacological intervention from several points of view. But also, as I told you before, also soluble factors are very, very important. TNF beta to regulate the excessive expansion of T cells has a very important role. TNF beta, together with interleukin 10, as you know, are released by T regulatory cell, and many investigators have shown how T cells are defective in their function, probably not in the number, in multiple sclerosis. It is a very important topic that have been not only considered for developing new drugs, but also was useful to explore the effect of several drugs. And again, interleukin 17, that is the main expressed by Th17, that is perhaps in not only in EAE but also in multiple sclerosis, probably the main effector of the disease inside the central nervous system, where clusterization of Th1 response is probably responsible for activation of macrophages and other cell types. And so again, this is an important possible target for pharmacological intervention. Try to switch the response from a Th1 pattern to a Th2 pattern that is simply may be considered anti-inflammatory. So this is the base, as I told you, the basic view of immunopathogenesis of multiple sclerosis. We can simply consider that a detrimental effect on the T cells and B cells probably may be effective in multiple sclerosis. And this was the case of cladribine, one drug now not approved for multiple sclerosis, but that was investigated for a long time. It is a Purina analog, and though it intercalates in the synthesis of DNA and give rise to cell apoptosis. Of course, this is much more relevant in cells who are rapidly multiplicating, like are all the immunocytes. It was developed. This drug was developed for the treatment of hairy cell leukemia. Hairy cells, you can see here, are this pattern of cluster designation on their surface. And as I told you, they lead to an apoptosis of all lymphocyte time with a very long-lasting lymphopenia. And this was this issue was the reason why the drug was not presented for registration in the regulatory agencies, but nowadays probably will come back and will have been reproposed. The effect of cladribine is much more relevant of rapidly dividing cells, as I told you before, causing cell death of apoptosis of the resting cells. And here is the result of the Clarity trial that considered 2 doses of cladribine. Oral cladribine in multiple sclerosis was considered in the oral form in comparison to placebo. And you can see more than 50% reduction of the annualized relapse rate, and also the cumulative number of relapses was strongly reduced in patients assuming the active drug. And also the time to first relapse, that is another important endpoint in all clinical trials. The time to progression. Time to progression is a very sensitive endpoint, but very difficult to be changed by any kind of drug for multiple sclerosis. As I told you before, the adverse events were mainly linked to itself on the mechanism of action of this drug. That is lymphocytopenia, as you show. This was present in around 20–30% of patients according to different dosages they assumed, but in a very small figure of in the placebo group. Herpes zoster reactivation also was a little bit increased in patients with activity, and this was a concern that was taken into account. But now, very recently, 1 year ago, a new trial was published with taking into account the administration of oral cladribine to multiple sclerosis patients, or I should say patients with the first attack of multiple sclerosis, what we call CIS. And by this way we can see how this treatment can lower the rate of a conversion to clinically defined multiple sclerosis. I will not consider pretty interesting, but a little bit complicated for us, question of what the difference between a clinically defined and McDonald-defined multiple sclerosis. Anyway, you can see the strong effect in delaying the occurrence of the second boot, the second relapse, with define the multiple sclerosis from a clinical point of view. And it was the reason why the company submitted again cladribine tablets for multiple sclerosis for registration in Europe. We are waiting for final decisions. This is another compound that was first considered for different diseases than multiple sclerosis. Is a derivative from a metabolite of a fungus, Isaria sinclairi. It is one of the several cases of drugs or prodrugs that comes from the natural environment. Is an analog of sphingosine, that is a complex lipid that is also structural lipid of the central nervous system. It was originally studied in organ transplantation in graft versus host disease. It's a prodrug. It's phosphorylated into the cell in sphingosine 1-phosphate. Since sphingosine 1-phosphate is then transported outside the cell, it has a high affinity and agonist effect on 4 of 5 receptors, which are very rich on lymphocytes and also on myocardial cells. And so the drug also modulated the expression of sphingosine 1P receptors on this kind of cells. And it acts as an inside-out signaling molecule. It means that we can see an important gradient of concentration of C1p, both in the circulation, in the blood, but also inside the lymphatic organs like nodes, like spleen. And we see how activated cell that show C1p receptor, if they are activated at the sphingosine-1 phosphate links to its receptor, they can cross the barrier and go outside in the lymphatic sinus and then enter in the lymphatic circulation. When we use such an analog of Fingolimod, this links antagonize the effect of on the receptor. And by these mechanisms, this activated T cell cannot cross this barrier inside the lymphatic sinus and cannot enter the circulation. So there is a compartment. The final effect is a compartmentalization of active lymphocyte inside the lymphatic organs, and they are not freely circulating in the blood, and by this mechanism they cannot enter into the central nervous system. It is a very interesting, tricky mechanism of action. Of course, this is also a little bit more selective for different kind of T effector cells, like memory T cell, because one concern was initially how this drug could, for example, increase, depress the protective immune system and give rise to reactivation of, for example, viral infections like herpes and like other more dangerous diseases. And this is partly true, but the interesting thing is that T effector memories are not involved by this complex mechanism, depending on the expression of chemokine receptor 7, that on the surface of this T effector memory cells cannot be are antagonized by the by Fingolimod and blocks the blocks the circulation, the free circulation of T central memory cell, but not effector memory cell, and so the immune system is still able to react against viral environmental interferences like viruses and so on. And so this is an overview of the effect of FTY, as it was called initially, this drug. It inhibits, as I told you, the recirculation of autoaggressive T cells from the primary lymphatic organs into the central nervous system. This is especially true and interesting for Th17, which are the main effector T cells in the pathogenesis of multiple sclerosis. But another important and relevant effect maybe is direct action inside the central nervous system, because it also crosses the blood-brain barrier, and almost not all, but several cells, neural cells, both neural cells and astrocytes, express on the surface sphingosine-1 phosphate receptor. It means that they can be modulated also by Fingolimod when it crosses the blood-brain barrier, and acts as a probably as a neuroprotective agent for multiple sclerosis. And this is very quite important, because up to now we have several drugs who are very active as with an anti-inflammatory mechanism of action. But already in the very early phases of the disease, the degenerative aspects of multiple sclerosis are very active. and we need, and we do not have any compound, any drug which is active on these aspects. And so FTY was probably demonstrated to be one of such a resource possibly active as an antigen-degenerative drug. Here are shortly the results of the most important trial who tested this drug, the Freedom trial. The primary endpoint was, again, they analyzed the relapse rate, and here we can show how it was reduced, strongly reduced by more than 50% against toward placebo, versus placebo. And this was true for both two different dosages. And again, considering this, another trial, the Transforms trial, we could confirm this strong action on relapse, on the relapse rate. And as you can see here, also the number of patients free from relapses are increasing in the treated patients in contrast to patients with treated with placebo. As I told you before, all these new drugs may have some drawbacks, and in fact, in this trial, in these two trials, two fatal infections were recorded: one for primary varicella zoster infection, diffuse infection, and one for herpes simplex encephalitis. And the other important adverse events were again herpes virus infection, and much less important, bradycardia, anteroventricular block, because of the direct action of this compound on the atrioventricular branch. And again, hypertension, macro edema were, I should say, less relevant side effect. However, this the risk. This drug introduced the concept of risk treating multiple sclerosis, risk of important and possibly life-threatening infections. Well, now we talk about another compound that it's available on the market since more than 1 year. And it was derived from leflunomide. Leflunomide was developed for the treatment of B-cell leukemia, and in 1998 it was licensed for the treating of rheumatoid arthritis and psoriatic arthritis. However, it was evaluated in these patients who were very frequently are affected by other comorbidities and are also being treated with other drugs, especially immunosuppressive drugs. And so there was a strong experience in this rheumatologic disease with the leflunomide. More than 42 million patients year cumulative exposure has been reported, as this constituted a strong basis for the proposition of another drug, a metabolite, the active metabolite of leflunomide, that is a teriflunomide. Teriflunomide probably is the active metabolite responsible for the therapeutic actions on in humans. Here we can see the possible primary mechanism of action of this compound is acts as an agonist of pyrimidine nucleotide pool of a pyrimidine basis, sorry, and it acts blocking the dehydroorotate dehydrogenase enzyme. This blocks give rise to the restriction of proliferation of rapidly active proliferating active lymphocyte. This mechanism leaves the other way of synthesis of nucleic acid. It means that only rapidly proliferating lymphocytes are affected by the drug. So primarily activated T cells are affected. And there is a salvage pathway for the pyrimidine synthesis. It should guarantee that the immunosurveillance is still active in patients assuming this drug. We can discuss if this mechanism of action define this compound as an immunosuppressor or immunomodulator. This differentiation for a pure immunologist is nonsense. From a clinical point of view, is important because when a drug is considered as an immunosuppressor, they give rise to many concerns about, as I told you before, especially viral infections. It is not the case for the pure immunomodulators like interferon, as we are used to call these compounds. Anyway, the experimental tests with this drug show that teriflunomide patient treated with teriflunomide can still have a proliferation of T cell when they are activated by mitogens or are activated by external antigens. And teriflunomide does not reduce the CD4, that is active, CD4 and CD8 blood counts. Is still it leaves the ratio of these two important subpopulations unchanged. In addition, it polarized T cell differentiation toward a Th2 phenotype, which is considered good. It's considered fine for multiple sclerosis, especially inside the central nervous system. It also can affect B cells activation through different pathways. Well, the pharmacokinetics of these drugs is quite original. It is linked to plasma proteins with a strong linkage, and is not influenced by food intake, age, sex, or hepatic impairment. But as I told you, being strongly bounded to blood proteins, plasma proteins, more than 99%, it means the half-life is quite long, 10 to 18 days, and the steady state is obtained within 20 weeks. It means that if we have to stop this treatment, we need to start another one. This can happen in the case of breakthrough disease, that is, patients who are rapidly changing their course, have important relapses and increase of disability. We cannot start immediately another drug. We have to wash out. Fortunately, the use of cholestyramine or activated charcoal can eliminate in 10 days, 15 days the drug from the circulating blood, and by this way we can start with another drug. Here we have the results of the effect of a teriflunomide on neutrophil and lymphocytes counts. It is a little bit down regulated, depressed, I should say, but not so strongly to give rise to concerns for infectious disease or reactivation of infectious disease. These are the clinical results in two very similar clinical trials in which several hundreds of patients have been treated, and we can see how there is a reduction of around 30% of the annualized relapse rate. This is a figure similar of the effect to the effect of interferons, to the effect of glutathione acetate. On this basis, it has the advantage of an oral administration in contrast to interferons and Copaxone, which are injectable, but the relative capacity of reducing the relapse rates is quite similar. And the same is if we look at progression, is very little bit influenced by the treatment. The same results were achieved by this different trial. Of course, as it's usual for us, for clinicians who are studying multiple sclerosis, the results are much more relevant, much more powerful if we look at MRI. MRI is a surrogate endpoint for us, but it's quite important because it gives us many informations about not only the appearance of new lesions, but also about the reactivation of all the lesion, damage of the blood-brain barrier, and most of all, the increase of atrophy. That is a new endpoint that we are going to study more and more frequently nowadays. And if we look at all these parameters, we can see this effect that is much more stronger than the clinical effect. And this is, you see, for example, it reduces by 80% the number of active gadolinium enhanced lesion at MRI. It is a very strong effect from a scientific point of view, but not from a clinical point of view, I should say. And this study patients were also followed up in extension studies which confirmed the effects on the relapse rate along, you can see, many years of observation. And also the new endpoint of patients with no evidence of disease activity from both clinical and the MRI point of view is similarly strongly affected by the treatment in contrast to placebo, and this is very significant. Well, this complex family of compounds, fumaric acid esters, have been developed in another field of medical investigation. Fumaric acid is and its derivative, monomethyl fumarate and dimethyl fumarate, are the compound, the metabolites and pharmacologically active. They are both present in the Fumaderm preparation that is available, was licensed in 1994 in Germany for the treatment of psoriasis, and can be given both on the skin and orally. The two compounds are present in different percentages, as you can see. And which is the pharmacological peculiarity of these different esters of the fumaric acid? Dimethyl fumarate is metabolized at the level of the gastrointestinal tract to monomethyl fumarate. This monomethyl fumarate peaks in a few hours after ingestion, but dimethyl fumarate cannot be release is not found in the systemic circulation. So there is the problem to bypass the stomach, to bypass the intestinal metabolism. And for this reason, a new formulation known as BG12, commercial name Tecfidera, was released. This compound is made only by dimethyl fumarate, but as I told you before, is converted into monomethyl fumarate and some fumarate esters inside the cells. What is interesting, very interesting, is that monomethyl fumarate can cross the blood-brain barrier, and so it can also act directly inside the central nervous system. Which are the molecules responsible for different therapeutical effects is not known. And also, there is no complete agreement about the real single mechanism of action. Probably this drug acts like interference, like Copaxone, through different metabolic pathways, through different and complex modulation of the immune system. That makes it very similar to interferon from a pharmacological point of view. You see, you can see dimethyl fumarate, as I told you before, since it's monomethyl fumarate is able to cross the blood-brain barrier, it also may have cytoprotective properties in addition to anti-inflammatory properties. And there are several experimental reports that demonstrate this different mechanism. It was shown also that it can switch, like many drugs for multiple sclerosis, can switch the T cell responsible from a Th1 pattern to a Th2 profile. And influences not only T cells, not only B cells, but also macrophages, microglia, astrocytes, and neurons, because of his particular pharmacokinetics. We know that he has a natural effect, antioxidative effect, that is much complex because it's mediated through different molecules. Dimethyl fumarate can reverse the linkage between the NRF2 molecule, that is the nuclear factor erythroid-derived number 2. When this one is free to cross the nucleus membrane, it's enter the nucleus, and here it can activate several give rise to the synthesis of several molecules, among which there are antioxidant molecules with antioxidant properties, different transporters, chaperones, proteasome, and so on. And this gives rise to a mechanism of detoxification and normalization of the metabolism of energy, and also give rise to molecules that may have a role in the repair of damage or degradation of damaged proteins. It means a very complex mechanism of action that was not completely understood up to now. A new mechanism of action has also been proposed and hypothesized recently. That is that this BG12 can have a neuroprotective effect. This is true for EAE. Through the activation of this particular receptor, the receptor 2 of the hydroxycarboxylic acid, and we can see how EAE, the animal model of multiple sclerosis, is strongly affected in mice treated with dimethyl fumarate or monomethyl, in this case dimethyl fumarate or monomethyl fumarate, instead of increasing the disability as is shown here in mice treated with ineffective compounds. and this gives rise to a very strong protective action in the central nervous system that is demonstrated in the number of lesions in the white matter. So, as I told you before, monomethyl fumarate had the peculiarity to cross the blood-brain barrier. It's which the microglia from its classically activated type to alternatively activated type that is probably neuroprotective. And it was demonstrated by an Italian group from Rome. The monomethyl fumarate can also modulate the release of glutamate. It's an important neuronal mediator, and that is released at the presynaptic terminals. And so this is another interesting possible mechanism of action that can give rise to modulation, not only modulation of neuroinflammation, but also a restoration of the synaptic dysfunction that is seen in animals and also in humans with destroyed myelins and damage of the normal axonal flux. We see here the clinical results into clinical trials involving several hundreds of patients, the DEFINE trial and the CONFIRM trial. Both demonstrated a strong effect on a relapse rate, around again 50% of a reduction of relapse rates in treated patients toward in comparison to placebo-treated patients. And also, if we consider the progression of disease that is normally measured through the EDSS scale, there is a strong, quite strong effect and reduction, around 30% reduction in treated patients in comparison to patients treated with placebo. Of course, disability progress anyway, but to a short, I should say, to a short rate in comparison to placebo-treated, untreated animals or patients. Here are the results of this, both the trials put together, involving more than 2,000 patients. You can see this strong statistical analysis confirmed and demonstrated the quite good effect of this drug again on the probability of having new relapses, on the probability to progress the disease. As usual, we can see always see a much more strong effect on relapse rate, not on disability. This is why, because the anti-inflammatory effects of all the drugs used for multiple sclerosis are much more stronger than the neuroprotective effects. And it is true, obviously, also for MRI parameters. I will not comment on this. Now, in the recent years, many monoclonal antibodies have been developed for multiple sclerosis, coming from the experience from other, the treatment of other diseases. I should say that probably the most important, the first one that was studied since more than 1 decade was the Campath-1 that was developed in Cambridge University. And is a chimeric monoclonal antibody directed against the human CD52 receptor that is present on the surface of many immunocytes, most immunocytes. There's that function of CD52 is not yet understood and has been implicated of the activation of the migration of T lymphocytes, and also acts as a co-stimulatory molecule that induce T regulatory cells, CD4, CD25, which is a distinct type of TRX, is different from FOXP. It's not here, FOXP3 cells. Anyway, the mechanism of action of this drug give rise to a long-lasting depletion of all circulating CD52 positive cells. These cells are really destroyed by an antibody-dependent cell-mediated cytolysis, a complement-dependent cytolysis. And is CD52 is expressed not only on the surface of T and B lymphocytes, is expressed also on by a lesser extent on monocytes, macrophages, eosinophils, and granulocytes. It means that it has a widespread effect on the immunocytes, on the circulating immunocytes. But probably NK cells and plasma cell, mature plasma cell, it means the possibility of producing antibodies seems to be preserved, like it is the T cell, T regulatory function and T regulatory cells numbers. Yeah, the experience of Campath-1 in multiple sclerosis, it was suddenly tested in this disease by the English colleagues from Cambridge. Firstly, they tried to use it in a chronic progressive multiple sclerosis, and here you can see how faint and how poor were the results. And this scale that show the EDSS, it means the measure of disability, the scale of disability. We can see how only one patient had a small improvement, while the majority of patients were almost stable or developed an increased disability. This was not the case for relapse and remitting multiple sclerosis, where the change from of EDSS, the scale of disability from baseline, was much more interesting because the majority of patients improved clinically after this treatment. And this was the basis of further investigation and development of clinical trials in multiple sclerosis. And we can see after one administration of Campath-1 how dramatically the annual relapse rates dropped down in patients who had a very active disease. Each bullet here represents a multiple sclerosis reactivation, a multiple sclerosis relapse, and you can see here how rare are the relapses after many days, 200 days. It is after years after one single dose of Campath-1. It means that this drug has this monoclonal antibody has a very strongly, very aggressive effect on T cells, a very strong effect on relapse rate, and it should be is indicated for very aggressive relapsing remitting multiple sclerosis. Campath-1 was a chimeric monoclonal antibodies, and after that, and trying to a reaction that were in some cases very dramatic, with cutaneous skin rash and also some cases of anaphylaxis. These monoclonal antibodies, humanized monoclonal antibodies, is directed again, of course, against CD52, and as I told you before, also in multiple sclerosis patients, it was shown it was shown to protect, to be not effective on neutrophils, on natural killer cell, T regulatory cell, T naive cell, and plasma cell. So a good profile as it concerns the immunosurveillance of the immune system. Moreover, additionally, it was shown to induce BDNF and CNTF molecules which are neuroprotective and are molecules that in the central nervous system have a very important neuroprotective effect. Now, the indication of Alemtuzumab up to now were only B-cell chronic lymphocytic leukemia as a second-line therapy, that is in patients who did not respond to first-line treatment with other immunosuppressors. And it also can be given as with an off-label way to patients suffering from cutaneous T-cell lymphoma, non-Hodgkin lymphoma, and graft versus host disease. But it was suddenly proved also in multiple sclerosis patients. We see the results of the effects in multiple sclerosis patients if we consider different type of cells. As I told you before, you can see how neutrophils are not affected by these monoclonal antibodies. There is, after the first dose, a small decrease of their number. After then is stabilized. They do not reach, after several months of observation, the baseline level, however, were always at the level of safety. You can see the dramatic effect, on the other hand, on lymphocytes. After a few hours after infusion, intravenous infusion of this drug, of these monoclonal antibodies, the cell count of T lymphocytes is dramatically lowered to almost undetectable, quite undetectable level, and is slowly increased in with a rate, a very slow rate that can be observed only if we consider many months. Monocytes, eosinophils, and basophils are not affected by this drug. But there is also a different effect on B cell and CD4 cell. If we see the effect of any single infusion of the drug, we see how CD19 B cells are repopulated in the circulation much more than it is for CD4 T cells. It means that this is a peculiar, the peculiar target of these monoclonal antibodies are probably CD4 T cells, while B cells are relatively spared, or I should say they are much earlier repopulated in the circulation. I told you about the effect on regulatory cells. There was a slide I was looking for previously. We can see how FOXP3, the percentage of FOXP3 positive cells are increased after the administration of Alemtuzumab. It means that probably this monoclonal antibodies is able to potentiate the defective Treg function that we see in multiple sclerosis patients, but it's probably a transitory effect, because we can see that there is a different expression of the so-called CD4 Tregs generated by anti-CD52 monoclonal antibody in comparison to FOXP3 positive cells, which are strongly depressed and increased transiently after between the third and the sixth month after treatment. I cannot give you an answer of this effect probably it needs further investigation to understand what does it mean. And so that as we concern FOXP3 regulatory cells, we are sure that this treatment shows a transitory effect of increase in their number. The clinical studies with Alemtuzumab were performed with one phase 2 and 2 phase 3 important studies involving several hundreds of patients in comparison to an active drug, not in comparison to placebo like we saw in the previous clinical trials I showed you. And all this studies be completed. Also an extension protocol ongoing. And here are reported synthetically the results, the clinical results of Alemtuzumab in a comparison of the phase 2 and the 2 phase 3 studies. We can see how the relapse rate again is strongly affected by the monoclonal antibody after one injection of monoclonal antibodies. I should say 2 injections because there is a reprisal of the treatment after 1 year usually. And this figure of more than 60%, more than 50% is should be considered in the light of the fact that there was an active comparator that was interferon beta, not placebo, and so it multiplicates the effect of the drug in comparison to the effect on placebo. Quite fine results were seen also for the accumulated disability, as we can see here. And now we have the results after the observation up to 5 years of patients who were initially treated and included in these studies. The retreatment, as I told you before, is usually performed after 1 year, but very low number of patients needs further treatment. And we can see here also the effect on the MRI. The reason for retreatment of patient after one year, it was for the appearance of new relapses in 51%, or reactivation of MRI in only 25%, and both relapse and MRI appearance of new lesions at MRI in 23%. And so we can say that the strong effect of this drug is maintained and after several years, and the majority of patients do not need any further treatment after the first dose and the second dose after 1 year. And 80% of patients were free from the disability progression confirmed in 6 months. If we look at them after 5 years of observation, it means a very strong effect. Again, the results are summarized with the parameter, with the endpoint of NEDA, no evidence of disease activity at both clinical and MRI endpoints. We can see how our patients after 3, 4, and 5 years, the proportion of patients with without any disease activity is very high, ranging 60%. And these are the same results split in a clinical about showing the effect on the patient with no activity at the clinical point of view, from a clinical point of view, or from MRI point of view, that even better, as I told you before, because MRI is a much more sensitive endpoint. Now, we are told we have looked long on the function of T lymphocyte, but in recent years, a great attention was given to the other arm of the adaptive immunity, that is the lineage of B cells. B cells in the periphery of the immune system have several important role, not only the processing of antigens and the production of antibodies when these B cells develop as mature plasma cells. They also have the ability of presenting these processed antigens to C cells, to T cells, and activate T cells. And also this is a quite important role that is not performed by dendritic cells and professional antigen-presenting cells like macrophages, but also B cells have this role. And this is much more important by the fact that these B cells are present in the central nervous system, as we will, as I will show you later. Once inside the central nervous system, B cells promote the release of important regulatory cytokines. I will not talk about in depth about this. They produce pro-inflammatory cytokines, and so can damage the myelin sheath, not only with antibody, the production of antibodies, but also by the release of soluble factors through the release activation of other cell types, interaction with other constitutive cells of the central nervous system, like microglia, and giving rise to an activated microglia that has an important inflammatory role in all inflammatory, but also in neurodegenerative diseases. I anticipated the fact that B cells are very important. But the fact that now we know that there are lymphatic nodes, I should say, what is the correspective in the central nervous system of the lymph nodes in the peripheral immune system, that is the accumulation of plasma cells and B cells on the surfaces of meninges, where they have a very important role of patrolling of the immune environment of the central nervous system and the protection against Lyme viruses. On the other hand, these cells, we know, are also the reservoir of some viruses, like the Epstein-Barr virus. And the Epstein-Barr virus was took in consideration the last few years as a possible trigger of the immune activation, of the mounting of an immune response inside the nervous system that possibly can give rise to the pathogenic mechanism of multiple sclerosis as a primary trigger of the demyelinating process. And this is the representation of what I told you about the presence of this foci of immune cells, and primarily B cells, and in the meninges, and also in the so-called gray matter plaques. For this reason, there is a potential role, or several potential roles of B cells in multiple sclerosis. Possibly they produce pathogenic antibodies. We all know how important are the presence of oligoclonal bands of IgG in cerebrospinal fluid that is commonly used to make a diagnosis of multiple sclerosis. But it represents not only a marker of disease, but probably it represents also an still unknown, unreveled presence of a B-cell continuous activation in central nervous system. In fact, the oligoclonal bands do not change in time. If we look at them in the early phases of the disease and look again after 10, after 20 years in the same patient, we found exactly the same pattern. It means that there are a few clones of B cells who are activated, are continuously reactivated a long time. And this is a very interesting point that make it possible that interfering with B cells is a potential, a very strong potential target of multiple sclerosis treatment. So we can change antigen presentation. I told you in the very first slides how there is a continuous production of new antigen, what we call the spreading of antigen in central nervous system. It means that possibly after each relapse, new antigens are released from the myelin sheath and are released in the central nervous system, and then enter in the peripheral immune system and give rise to another wave of immune stimulation. I told you about the role of Epstein-Barr virus as a possible trigger of chronic inflammation MS, and Epstein-Barr virus has have been demonstrated to be present in the B cells of the meningeal surface in chronic progressive patients. Moreover, B cells can also have a suppressive function through the production of interleukin 10. Possible mechanisms of action of anti-CD20 therapy in multiple sclerosis was absolutely a rationale of after the consideration we made before that we can possibly treat patients with anti-CD20 monoclonal antibodies. In order to eliminate a CD20 positive cell and obtain also an immunosuppression of T cells because of the properties of antigen presentation that B cells has on T cells. And after then, a possible anti-inflammatory effect, diminishing the pro-inflammatory cytokine production by B cells, and also the reduction of the general antibody in the peripheral immune system. Now the expression of different antigens on the B cells is different in different phases of maturation. There is a substantial overlapping of CD20 and CD29. There are other determinants which appears much more later in the development of plasma cells. What have been studied are monoclonal antibodies against CD20. The first one on the market was rituximab. That was a chimeric monoclonal antibodies against CD20 expressed on B cells and mature B cells, as I showed you before, and is involved in B cell proliferation and differentiation. Is licensed for treatment of non-Hodgkin lymphoma and systemic lupus erythematosus, rheumatoid arthritis, which are refractory to other therapy. Is administered intravenously and usually is given in a short courses at different time points. there is a small proportion of T cell and NK cells that also express CD20, and probably this may have an important but not already known effect in multiple sclerosis and in other diseases. What's important that the treatment with anti-CD20, unexpectedly from some point of views, it give rise to an increase of CD4 regulatory cells of different subset after several days after infusion. It is an important thing. As I told you before, the production of IgG in the CSF is a hallmark of multiple sclerosis, and we see here how is while CSF concentration it is slightly reduced by CD20 antibodies, but not in all patients. On the other side, the synthesis rate of IgG is quite depressed in treated patients. And we show how the oligoclonal band number is substantially conserved. I told you this is a real signature of the single patient. The effect on B cells, on the other hand, is much more stronger than the effect on antibodies. And we see how after rituximab, one course of rituximab, after 24 weeks, B cells are almost absent in the cerebrospinal fluid, and how also T cells are strongly depressed in cerebrospinal fluid after rituximab in infusion. So I was talking about how yes, a single course of rituximab reduced inflammatory brain lesions and clinical relapses for 48 weeks. It was the results of a phase 2 trial with rituximab in multiple sclerosis. Is demonstrated with the endpoint of MRI, surrogate MRI endpoint, how the total number of lesions was strongly depressed after a single injection, and also the appearance of new lesions was reduced to a zero level, in contrast to patients treated with placebo, who showed a constant appearance of new lesions along the period of observation of 48 weeks. This data provided good evidence of the involvement of B cells in the pathophysiology of multiple sclerosis, and was the premise of further studies that have been developed. However, the use of rituximab, as in other diseases, has a strong caveat in the fact that it can give rise to multifocal progressive leukoencephalopathy, that is a very severe disease of the central nervous system. And several antibodies has PML as a possible drawback in long-term treatment. But this is an alert of the Italian regulatory agency to make very the clinician quite conservative in the use of off-label of rituximab as a off-label treatment in multiple sclerosis instead of treating oncological diseases. For this reason, another antibody, a humanized antibody, was developed, that is ocrelizumab, that it acts against the same CD20 determinant with which has a different, a small epitope difference, but is quite mostly overlapping with rituximab, give rise to a quite similar rapid depletion of B cell, which is immediate after the first course of treatment. And in the phase 2 trial, it showed a good safety profile. This was the reason why it was also studied in well-developed phase 3 studies, which were informed by the results, preliminary results in rheumatoid arthritis, where the findings were not so good, but because of the fact that, as I told you before, that concomitant immunosuppressive medication are usually utilized in patients with rheumatoid arthritis, and so this is the reason why in this phase 3 trials in rheumatoid arthritis they found a high rate of infection that was an important aspect taken in consideration when we studied also multiple sclerosis patients. Here are the results of the two important phase 3 trials in multiple sclerosis, OPERA 1 and OPERA 2 trials. This is in short the design of administration of the drug that was initially administered in 2 doses, which were repeated after 24th and 26th week after the first one. The results here are compared for the 2 studies, absolutely overlapping, a strong effect of a little bit less than 50% reduction of the annualized relapse rate, again in comparison to an active comparator like interferon beta. And so again, I would like to recall that this effect should be amplified by the effect of the active comparator, not the placebo. Very strong results when we look at MRI, almost complete reduction of at 0 level of the appearance of new lesion in MRI in both studies, as you can see here. And these are the effect on the different on the active gadolinium enhancing lesions that are strongly depressed to 0, and even after more 144 weeks of observation, and this is a very, very strong effect in comparison to interferon beta or placebo, who are quite similar as shown here. Well, going rapidly to the final slide and the conclusion of my talk, I would like to recall which are the most important new drugs developed for multiple sclerosis, coming from the experience in other treatments in other diseases. We saw how the blocking and compartmentalization of T cells are much important, and the result is achieved by Fingolimod, which inhibits the crossing, the migration and recirculation of lymphocytes in the peripheral lymphs. And the effect of a complex effect of other drugs like Teriflunomide, which act with both anti-inflammatory and neuroprotective action on both T cell and B cell lineage. How B cell lineage is specifically targeted by rituximab and other anti-CD20 antibodies, who are also going to be developed in the next few months or years. How Alemtuzumab anti-CD52 by itself, like other drugs, acts on T cells and B cell, but with a much more stronger effect because it acts as a real immunosuppressor, because it destroyed by apoptosis both these T cell, the T cells, most of the T cells, and in part the B cells lineage. We did not talk about natalizumab, it is an anti-integrin monoclonal antibodies, but because it was developed specifically for multiple sclerosis, in my knowledge, was not tested in other diseases before. No, it's not really true because it was used for also in Crohn disease, where it was not. It was studied in parallel with multiple sclerosis, but it was not approved because of side effect. We do not talk about daclizumab, it is anti-25 antibodies that is specifically studied for multiple sclerosis. It depresses not only activated T lymphocytes because it acts on the interleukin-2 receptor of this on the surface of these cells, but it also gives rise to an increase of natural killer cells that probably is the most important mechanism of action of this antibody. The final slide that show you my colleagues. I wanted to thank them for their patience and for their collaboration in treating multiple sclerosis patients in Gallarate Center. Yes, some people are missing, and are patients who are the most important actors of our work and target of our job. Thank you very much.